Hello and welcome to this HCP Live Peer Exchange Advances in the Management of Inflammatory Bowel Diseases. I'm Dr. Miguel Reguero from the Cleveland Clinic. Joining me today in this discussion are my colleagues, Dr. Jessica Allegretti from Brigham and Women's Hospital. Hi, Jess.
Hi.
Dr. Marla Dubinsky from the Icahn School of Medicine at Mount Sinai. Hi, Marla.
Hello.
Dr. David Rubin from the University of Chicago. Hey, Dave.
Hey, Miguel.
And Dr. William Sanborn from UC San Diego. Hi, Bill.
Hi, how are you?
Doing well. Our discussion today will focus on the management of inflammatory bowel disease using biologics and the paradigm shift away from a therapeutic strategy that traditionally has relied on corticosteroids and immunomodulators. So with that, let's go ahead and get started. So we have some different segments, and we're going to start off by talking about the pathogenesis and pathophysiology of IBD. I realize with this group that we could probably spend an entire conference on this, but we're going to distill it down to about 15 minutes. I'm going to ask each of you some questions, and then we'll also have discussion along the way. If you do want to chime in or add something, please feel free to do so. So Bill, I'm going to kick it off with you. And when we think about the pathogenesis of inflammatory bowel disease in 2020, what are some high-level thoughts, or what would you say is the current understanding in the pathogenesis of Crohn's and ulcerative colitis?
Well, some of the learnings we've had over the last decade or more are that ulcerative colitis and Crohn's disease are in some ways more similar than they are different. In terms of shared genetics, there's about 250 gene associations now, and many of those are shared between the two diseases and between many other autoimmune diseases. So they have a fairly common genetic background, but not identical. That's the first thing. The second thing is we always knew that the environment was important, and I think we still think that there are some very important unidentified external forces that impact the actual occurrence of IBD in the genetically susceptible person. But what we've come to understand is that our microbiome external environment in the lumen is a huge aspect, and we're still in the very early days of understanding how that directly impacts individual patients, but I believe that that will be an important part of the future. And finally, Marla can speak to very early onset Crohn's disease, where we see monogenic immune deficiencies in a certain proportion of patients, which seem to be quite unique.
Yeah, so obviously in the very early onset IBD, which many of us actually don't see aside from Marla, clearly a genetic factor there. So maybe Marla, you can speak.
Although don't forget, those patients grow up. We actually do see them, and they're probably in our practice today, and we've forgotten that they were onset when they were 5 or 6, and we haven't checked those genes.
Yeah, those are usually the patients when we present at conferences that are so severe, failing everything, and probably the reason, Bill, to your point, is that they're not the typical IBD patient. So Marla, if you want to talk a little bit about genetics, but let's move to the incidence and prevalence of IBD and maybe some aspects of quality of life. But what do we know about incidence and prevalence of IBD in the United States, North America? Tell us a little bit about that.
Sure. It's estimated that anywhere between 1.5 to 3 million people have inflammatory bowel disease at any given point in time. The reason why I give such a wide range is some numbers come, for example, from the CDC estimating around 3 million. Other numbers sort of hint at the fact that it's maybe somewhere in between, because I don't think we really know the true reporting of patients with IBD. We do know that it's approximately 50% of these cases of UC and 50% of patients have Crohn's disease. We know it's sort of around that, which means around 750,000 UC, 750,000 Crohn's. I think we do see that Interestingly, epidemiologically, the two age groups that are, or the one age group in particular that is the highest rising new cases is actually pediatric cases. And interestingly, bringing it back to the genetic comment that Bill made, the younger, under age of 6, is this 2 to 6 age group is probably the fastest growing new onset cases of IBD. Which speaks to the fact that the younger you are, genetics are playing a major role, as opposed to maybe environment, for example, which would probably be older patients have equal influence of genetic and environment. I do want to pinpoint what you guys were saying about the VEO, or what we term very early onset, which is under the age of 6, but then there's this sort of infantile IBD, which is this Crohn's-like illness between the ages of 0 and 2. And those individuals tend to have a very strong monogenic, as Bill was referring to. What's interesting, the genetic piece may be tied to this refractory nature that you're talking about. And now that we have commercial use or widespread use of these gene panels, we're able to test patients for common genetic variants like chronic granulomatous disease in patients who have recurrent perianal infections and abscesses. And we've been able to find a number of those. So that's sort of the epidemiological idea around IBD. And I do also, from a quality of life perspective, I think we have to recognize that this disease classically has been a relapsing and remitting disease, meaning it goes in phases. Obviously, our goals as physicians is to try and make it remit for that long, durable period. And I think when we get into the therapies, we'll talk about this new target of ours, which is complete deep remission. But I think you have to understand that every time a patient flares, the anxiety around not knowing when I'm going to flare, am I sick, is tomorrow I'm going to eat something, I'm going to ignite a flare, that is a very stressful and provokes a lot of anxiety for patients, the unknown about the quality of life tied to these diseases.
Good. Yeah. And I think, it's interesting when you look at the quality of life related to IBD and many of the studies that have been done. In terms of chronic illnesses, this has one of the highest impacts, meaning poorest quality of life. So I completely agree. And I think that's something that will be a theme throughout some of the discussions we have now in terms of treatment and looking at quality of life as really an outcome.